much, Dr. Mwai, and we are glad to have you in this seminar series. The floor is yours. Welcome. Thank you.
Thank you very much, Dr. Mary Beth Maritim, and it's my pleasure to be invited for this meeting. As you have rightly highlighted, is that I am a health economist who really delight pleasure in pushing for healthcare financing that really give us several things. Key among them, the fact that the law of resource mobilization for health, the battle can never be won without investing in prevention, because as long as the tap is actually running, then it means that we continuously have funding that comes into service delivery. And in that funding for service delivery, what happens is that it is never enough, because we continue to get more burden that we require to finance. So I want to, this afternoon, talk about primary healthcare and investment case for it. And just thought about the real journey that the primary healthcare work, as well as the UHC work, has navigated over the years. Since Kenya, became independent in 1964, we see a pathway that is presented that the country has tried to navigate to try and, improve access, cover for financial, protection for those providing care, as well as really improve the quality of care that is provided. So that's the journey, and really I may not go through each of the steps in the interest of time, but the Alma-Ata Declaration brought into focus, actually brought into focus again the importance of taking interest into investment in primary healthcare. And this country has been leading from the forefront, that is our country. And in doing this, we could see that we have moved to the launch of universal health coverage, and also the fact that Kenya established its pre-HC strategy, which is a guiding document on how we need to invest in primary healthcare. That was around 2 years ago. After that, we moved on to look at the operationalization of primary healthcare through the primary healthcare networks, which is a model of a hub and spoke model that outlines how we interlink facilities with the interest of delivering primary healthcare. This is by using the network of facilities, both public and private, at that level. So this is where we have come to, and with the launch of the primary healthcare strategy, as well as the launch of the community strategy itself, then that sets base for the level 1 and 2, as well as the community level, level 3, sorry, 1, 2, and 3, which are the main, investment areas for primary healthcare. Why this primary healthcare? The key important thing is a paradigm shift from the current setting, where we are largely firefighters as a nation, and even largely in the sub-Saharan Africa, our investments are in firefighting, curing of diseases, with a little regard to the prevention component, which is more sustainable and speaks to the long run ability for the country to fund itself. And COVID has taught us better on this prevention approach, with the simple washing hands and the wearing of masks. We have seen quite tremendous reduction in some of the communicable diseases beyond the COVID. Of course, the issue of the haphazard assignment of facilities, and facilities are established without a plan, and this makes sure that the investment case for these facilities is not grounded. But when there is a catchment area that have a defined need for services driven by the burden of disease and the epidemiology of the same, then it becomes very critical to actually, map the epidemiology environment to the facility needs, to the financing, to the inputs required, and more so, to have a more efficient system. So the community health then become a critical link at that level, in this paradigm shift, be able to address the challenges that our healthcare services are facing, and more importantly, taking services closer to the people, which is also aligned to the government of Afya Mashinani. So within this network, for those who have not maybe seen the approach, the main approach here is that, it's a network of facilities that are grouped together. And when we look at from the community level, we find that the system is organized in a way that the services are, have one hub, and this one hub is a level 4 facility providing such kind of services. And then we have 5 level 3 facilities, we have 5 level 3 facilities, and we have 30 community health units. This community health unit, each is made of 10 community health volunteers as of then, each community health volunteer is able to reach at least 100 households, which they are located for. So you see, we have from down one hand, each household is linked to a community health volunteer who is linked to a community health unit. The community health unit is supervised by a community health assistant, and that is linked to the primary healthcare facility. This is level 2 and 3 dispensaries and health centers for those who are Kenyans, and that is linked to a level 4. So we have a sequence of referral, as you can see, that making these facilities to have both horizontal and vertical referrals and making it efficient. And more importantly, the distribution of these facilities is so good that it can be able to handle at least 70% of the Kenyan disease burden. Now, having highlighted that, I just want to highlight from the financing component that financing and service delivery are linked, and they are actually, the brothers or sisters, so to speak. And for them to be able to, for one to be able to deliver service delivery that are efficient, then you need financing. And therefore, to what the healthcare sector have for many years been unable to do is to talk to the outside world or people who are non-medical to understand the language of resource allocation. However, the sector many times must be confronted with the desire to make a case for investment and bid by showing what do I get from the resources that we invest. So it is against this background that this analysis was done with support from UNICEF, working very closely with the Ministry of Health, to actually be able to estimate what's the rate of return of primary healthcare investment. Just to give a background, an earlier rate of return for investment in community health alone had given a return of 10 for every shilling that is invested. And therefore the question was, when this is interlinked with the facility, because community is at level 1, when this is interlinked with the community, then what is the evidence in terms of resource availability? Just to explain the modeling, more so the economic modeling, how it works, is that when someone is, either sick, what happens is that the disease affects the economy largely in 2 ways. One is that there is a transmission that gets into economic development when a person works suboptimally. They are at work, but they are not working optimally because of a disease. That is where you find you are working, you feel like sleeping, you sleep a little, you wake up, you are not really giving the best you could in terms of productivity. That's the first component, which is what we call presentism. You are present, but you are not really giving the best. The other thing is that you might miss a day of work or not come to work. That means you are absent from work. And therefore, you don't give the production that you would have given per day if you were able, to be at work. The other thing is that if the disease is not treated and you come to term, so you pass on, you lose some years of work that you would have worked and generated income for this economy. And therefore, we find largely the issue of sorry, we find the issue of lost productivity becoming a critical component driven by both presenteeism, absenteeism, as well as lost years of work. And that have a direct effect into the economy. So when all this is combined then with the opportunity cost in terms of treatment cost that you also incur when you get sick, then that gives you the large outlay of what it means to have the disease. So the main methodology, of course, was the preparation phase, where the data collection, the economic analysis, and of course the utility, which is a high-level advocacy for inclusion of primary healthcare as a main driver of the way we should be providing our healthcare services, and also, inclusion into government priorities, so that it become our key agenda through which the universal health coverage, debate and process and approach should actually be seen from. So in terms of approach, one must come from the estimation of the cost of care or cost of interventions that are PHC in nature, and the efficacy as well as the ability to, reduce disease preferences in country. So the costing was based on activity-based costing, and the cost of service in terms of difference from level 1, 2, and 3 was approached from the One Health model by WHO. And the cost effective benefit analysis as well as effectiveness analysis came from one estimation of daily aversion. This is from the burden of disease approach, and monetization of the same to get the daily values in terms of the value of what is lost. Now, the last thing, of course, is looking at the total benefit vis-a-vis the investment that is required coming from the intervention. So that ideally outlines what I have highlighted, the approach of the analysis. So in terms of costing, I've highlighted there is a PHC costing data, which ideally use the activity-based costing model, the One Health model for the projection of benefits. And we also had the other models that are critical in estimation of the impact of the investment, driven by different models that have been done, although majority of them are found within the WHO One Health suite. Of course, there is a merit and demerit of using this. And the key main one was the fact that in terms of demerit, is that the usefulness of the PHC data, as we see it, is largely driven by the available the available data, which of course determine the quality, which happens to be what happens in many other studies that are done. And of course, we have many benefits that are useful in using the One Health, spanning from the fact that it can estimate benefits across many programs. It is able to, one is able to simulate different changes across the benefit suite that arise from implementation of primary health interventions. And of course, it's a tool that is readily available and can be scaled in other African countries, really see the benefits that we have across these countries. So the comparison between the cost, which is ABCM tool, and the impact tools, because there are several, give us the rate of return. The formula is as simple as benefit over cost. So from our analysis, we found that the implementation of the PHC interventions at full scale for the next 5 years have effects that lead into saving children death at a level of 25,000, maternal death at 6,000, number of stillbirth averted at 15,000, stunting averted was at 410,000, anemia in pregnant women at 251, malaria death averted 20,000, and the number of malaria cases averted at 778,000. So these are the results of 5 years of continuous implementation of primary healthcare interventions across our primary healthcare facilities, as well as the community level, which is our other level of service delivery. So in summary, we find that we realize that over the next 5 years, the averted DALIs were at 64,430,316 over the next 5 years. And that aligns from what is presented on my right, which is YLL, these are years of life lost, and then YLD, these are years lived with disability. So due to stunting, by NCD, by anemia, TB, malaria, and then we had a combination of the other diseases that are actually seen at that level, of primary healthcare. This is in line with the Kenyan guidelines of the same. The value of statistical life year used is at 358,567. The economic burden, when we look at it from here, we find that the cost of investment for 5 years would not be little, and it will be to a tune of 1.65. This is a trillion Kenyan shillings. And then we find that we have 21.5 trillion. This is what comes from premature death, absenteeism, as well as a reduced productivity due to disease. In terms of the cost of investment, the 1.65 trillion shillings becomes an estimate of 34,772 per capita in 5 years, which means we are talking about 6,950 per person per year, which translates into 27,818 per household. So that is the breakdown of the investment per person for the PHC to be operationalized for the next 5 years. In terms of the accruing benefits, we have cost savings. It's far cheaper to treat healthcare, to provide healthcare in lower level facilities. And within 5 years of shifting service delivery closer to the people, the cost savings from the system was estimated at 198.2 billion shillings for the 5 years. Now, that is again by operationalizing the primary healthcare level. Second is that we have 21.5 trillion shillings, which now does include the productivity gain and social value of health, which is estimated for the 5 years. So this is the benefit that we get from injecting a 1.65 trillion shillings in 5 years in the country of primary health. And this is when we have organized our system again within the networks that I described within my earlier slides. So this gave us a cost-benefit ratio of around 16 shillings per 1 shilling that is invested. And this is, saying that per DALI averted, the cost was coming to around 246.5 US dollars, given the exchange rate of the day, that was around 25,635 shillings per each DALI that is averted. So from here, we see critical things. One is that there is a real value in implementation of the primary healthcare interventions. There's real value in aversion of disease by preventing diseases at that level. And that value is far much better compared to the value we get in very many other sectors. And in case good example is loads. For instance, if in load you get a 35–40% return is humongous. But we find that there are also other sectors of our economy, including the health sector, that can give us better investment in this. And therefore, we should invest in healthcare as a growth invention rather than investing in it for resource mobilization or for removing diseases. But it's a pathway of creating wealth within a country. And we feel that this is an approach that should be adopted by the governments, not only my government in Kenya, but as well as other governments across the world, to make sure that we operationalize. As I close, a key important thing that we have also learned as we did this analysis is that the largest cost accruing to the demand side of the healthcare system, these are the people who need to be treated actually. The biggest cost that accrue to them is cost of treatment, is cost of transport, which is removable or avertable, or we can save it by just taking services closer to the people and making the primary healthcare to function, to have the right medicine, have the right human resource. There is a return to it. So with that, Chair, I want to say thank you very much for the opportunity to make my presentation. Asante.